I'm Harriette Van Spall, cardiologist and associate professor of medicine at McMaster University, and I'm absolutely honored and delighted to have Dr. Milton Packer, who is distinguished scholar in cardiovascular science at Baylor University Medical Center in Dallas. And he is here with me to discuss the effect of empagliflozin across the LV ejection fraction spectrum based on individual patient-level pooled analyses from the Emperor-reduced and Emperor-preserved trials. Welcome, Professor Packer.
Oh, Harriette, Milton, please, I'm delighted to be here. It's great to join you again.
I was delighted to see the presentations at ESC this year and honored to discuss the results of Emperor-preserved with Dr. Anker prior to his late-breaking clinical trial presentation. Why don't you tell us the rationale for this pooled analysis?
So Emperor-reduced and Emperor-preserved were almost identical studies. They had almost identical verbatim protocols, statistical plans, investigators. They were done at the same time. The major difference between the two was an ejection fraction of 40%. Or less in Emperor-reduced, greater than 40% in Emperor-preserved. And so this is an ideal situation for an individual level, patient level pooled analysis. That analysis involved 9,718 patients across the whole spectrum of heart failure. And we focused on both heart failure events and on renal events.
So why don't you tell us something about the background characteristics and what you noted in the change in characteristics as the EF increased? It should put the results in context.
So the baseline characteristics of the patients were really, really interesting. If you did cuts at ejection fractions ending in 5, 25 to 35, 35 to 45, et cetera, we find that at the lowest end of the ejection fraction, we see primarily a population of younger men with ischemic heart disease and extremely high levels of natriuretic peptides. On the other end of the spectrum, patients with ejection fractions of 65% or greater, we see predominantly elderly women with hypertension, with a very high incidence of atrial fibrillation and only borderline increased levels of natriuretic peptides. So major differences in the demographics across the spectrum of heart failure.
Okay, and the patients received empagliflozin at a dose of 10 milligrams a day across both trials. What did you find in terms of the effect of the drug on the primary composite endpoint and on the renal endpoints?
So on the primary endpoint, we didn't find much of an influence of ejection fraction on the effect of empagliflozin. But remember, the primary benefit of empagliflozin is to reduce heart failure hospitalizations, not to reduce cardiovascular mortality. So we focused on heart failure hospitalizations, specifically looking at time to first hospitalization and total heart failure hospitalizations. And it was really interesting because as we go through the spectrum of patients with ejection fractions all the way from less than 25 to less than 65, we see absolutely the same magnitude of effect of empagliflozin in reducing the risk of heart failure hospitalizations, about a 30% reduction in risk, consistent exactly the same across all the ejection fraction subgroups. And then we see in patients with an ejection fraction of 65% or greater, a sudden attenuation of the effect. The drug has now a hazard ratio of 1.0 instead of a hazard ratio of 0.7. So a very sort of interesting horizontal line followed by a sudden upward shift at patients with an ejection fraction of 65% or greater. So a really wonderful effect of empagliflozin in patients less than 65, and no discernible effect on heart failure hospitalizations in patients with 65% or greater.
Right, and importantly, there was a reduction in severe illness among those who were hospitalized for heart failure. So you saw some reduction in heart failure hospitalizations that required inotrope support. Is that right?
Yes, we recently published in Circulation the fact that that when the patients were hospitalized, these were real hospitalizations. These were not just modest hospitalizations. These were hospitalizations requiring intensive care, hospitalizations requiring intravenous vasopressors and positive inotropic drugs. And empagliflozin reduced the risk of hospitalizations of this kind of severity compared with placebo.
Right, and I bring it up because there has been some note and discussion that empagliflozin did not reduce cardiovascular death and merely reduced heart failure hospitalization. But heart failure hospitalization has a tremendous burden on patients, on healthcare systems, and on patients' loved ones. So this was a worthwhile endpoint to see a reduction in. Now, I wonder if you would comment on the proportion of overall hospitalizations that are due to heart failure among patients at the higher end of the EF spectrum, because this is different from those at the lower end of the EF spectrum, wouldn't you say?
Yes. So in patients with heart failure reduced ejection fraction, heart failure hospitalization comprises a majority of their hospitalizations. In patients with heart failure in the preserved ejection fraction, heart failure hospitalization represents a minority of their hospitalizations. And that's because these patients have so many comorbidities that cause hospitalizations. And so we're seeing a difference across the spectrum. About 2/3 of the hospitalizations at the lowest end of the spectrum are due to heart failure. 15 to 30% of the hospitalizations at the highest end of the spectrum are due to heart failure hospitalizations. But the heart failure hospitalizations are the most serious hospitalizations that these patients experience. So we did an analysis where we looked at the use of intravenous vasopressor and positive inotropic drugs across all hospitalizations, not just heart failure hospitalizations, all hospitalizations for any reason. And in patients, even at the higher end of ejection fraction, a significant reduction with empagliflozin compared with placebo.
Right, and across many high-income countries, heart failure hospitalizations in general account for longer lengths of stay and higher costs than hospitalizations for other causes. So again, reducing the burden of heart failure hospitalizations has a tremendous impact on our healthcare systems. I wonder if you would comment on what clinical trial evidence to date tells us about the way we classify heart failure by categories of EF. So we've had this historic classification of heart failure in terms of reduced EF, mid-range EF, and preserved EF. And yet we see that LVEF is a continuum, and our response to therapies reflect this continuum. At the lower ranges, we see a reduction in heart failure hospitalizations, as well as cardiovascular and even all-cause death. And as EF increases, we see that there's a shift to a reduction in heart failure hospitalizations, but not necessarily all-cause or cardiovascular death. What do you think that tells us about the way we classify and offer therapies to patients with heart failure? Is it appropriate? Should we change the framework within which we provide care?
Oh, God, this is such an incredible question. So in 2003, the CHARM investigators invented a cut point of ejection fraction of 40%. And so that divided people from HFrEF, heart failure reduced ejection fraction, from HFpEF, heart failure with a preserved ejection fraction. 40% had no pathophysiological meaning, no clinical meaning. It was an arbitrary number. And then several years ago, European Society of Cardiology proposed mid-range ejection fraction. Oh, we'll take people with heart failure, preserved ejection fraction. We'll cut off the lower end 40 to 50%. We'll call it mid-range or mildly reduced ejection fraction. And people greater than 50 have HFpEF. And they just embodied that even further in the recent guidelines just issued a week ago. Well, the problem is 40 was arbitrary and made no sense. 50 is arbitrary and makes no sense. None of this is evidence-based. None of this is evidence-based. My own personal sense is if you look at most of the drugs, they have an attenuated effect at 60 to 65. I actually think that people with heart failure with a ejection fraction of 60, 65 are really, really different. They're really odd. That's a clinically relevant subgroup. But in most of the patients throughout the broad range of ejection fractions, making distinctions based on the ejection fraction cut point of 40 or 50 makes no sense at all.
Do you think, though, that there is a threshold, as you described, which is a 60 to 65% cut point, beyond which we should make efforts to look for HFpEF mimickers that can come in the form of infiltrative cardiomyopathies, phenotypes that might have their own specific therapies that might not be driven by the same underlying mechanisms that account for heart failure at the lower range of the EF spectrum?
Well, I think that people with ejection fraction 65% or greater are different, but I don't know if they have infiltrative cardiomyopathies. I don't think they have amyloid. Most of the patients who have cardiac amyloid are men with ejection fractions of 40 to 60%. They're not at the highest range. And people with amyloid also have markedly increased natriuretic peptides. That is not what we see at the highest ejection fraction. I actually think a lot of these patients have dyspnea from non-heart failure causes. They have dyspnea maybe due to atrial fibrillation, dyspnea due to other conditions, comorbidities. They may not have dyspnea due to heart failure because remember, their natriuretic peptide levels are just borderline.
Right. And I think that our earlier comment about the burden of cardiovascular and heart failure causes of decompensation and how that changes over the EF trajectory speaks to this underlying non-cardiac mechanism that's more prevalent as the EF increases. Patients present with the syndrome, but not necessarily cardiac causes of heart failure. Can you explain?
So it's really interesting. I wonder if patients really are presenting with the syndrome. So patients are presenting with multiple comorbidities. And a physician measures the natriuretic peptide and finds it to be 8,900, and the patient has atrial fibrillation. Well, a lot of people who are elderly, who have atrial fibrillation, have N-terminal proBNPs of 900, and they don't have heart failure. Now the physician, finding this, says to the patient, "Are you short of breath?" And the patient says, "Yes, I get short of breath on occasion." And now the physician makes the diagnosis of HFpEF. But the diagnosis isn't driven by the presenting complaint of dyspnea. It's driven by the comorbidities, the increased levels of natriuretic peptides, and dyspnea is now elicited in retrospect. I think that's what's happening to many of these patients.
Right, and we've done some machine learning analysis to discern clusters of phenotype, and we've found that lung disease is actually quite prevalent at the higher range of the EF spectrum. So patients may present with dyspnea and be inappropriately diagnosed as having heart failure, but in fact don't have heart failure. What fascinating findings, and who better than you to put it all together for us? Do you have any last minute thoughts about what the breadth of evidence from the trials you have led tell us about heart failure and what we need to do to change the way we provide care to actually improve outcomes in a meaningful way for our patients?
So we have four cornerstones of treatment. We have angiotensin receptor neprilysin inhibitors, beta blockers. We have mineralocorticoid receptor antagonists, SGLT2 inhibitors. And now we have evidence that the benefits of these drugs are not just focused in patients with a reduced ejection fraction. They span a broad range of ejection fractions. They span most patients with heart failure, regardless of ejection fraction. Sadly, we don't have a lot of data with beta blockers in patients with ejection fractions of 50 to 65%. But interestingly, in the clinical trials of HFpEF, 80% of people are getting a beta blocker. So the pillars of heart failure, the four pillars of heart failure, are not ejection fraction dependent. And that's such an important lesson. We have to implement these drugs and not be obsessed with the measurement of ejection fraction.
Okay, that is a very important take-home point. One that I think is transformative and one that we all need to buy into to offer therapies to patients who have heart failure without boxing them into these arbitrary categories that we have historically done. Thank you so much.
Especially, Harriet, especially since if you don't like the value of an ejection fraction on a Tuesday, all you have to do is repeat it on a Wednesday and it'll be different.
Right. Well, it is a very load-dependent measure, and there is intra and interperson variability in our quantification.
The worst biomarker ever invented by cardiology.
Useful for including patients in clinical trials historically, but I agree there are certain practical aspects to using it and measuring it, and particularly if you're assessing reverse remodeling, perhaps response to therapies, but overall shouldn't.
If you want to measure reverse remodeling, measure volume. Don't measure ejection fraction. Yep.
Okay. Point taken. Thank you so much for this discussion that I enjoyed. It's always such a treat to talk to you. And I look forward to talking to you again. I'd like to invite you back to talk about your research career and building a research career, because I think there's so much inspiration to be had from your career and your life. I'd like to have you back again, okay?
Thank you so much. I'm delighted. I would be delighted to come back.
Wonderful. Take care, Dr. Packer.
Take care.
Look forward to
Talk to you
having
soon.
back
Take
again.
care. Bye-bye.
Okay, bye-bye.